Hey there, health enthusiasts, welcome back to our channel. Today we have an intriguing topic to delve into: hypertrophic pyloric stenosis. But before we jump in, don't forget to hit that subscribe button and ring the notification bell, so you never miss out on our latest medical insights. Now, let's get started. The most common cause of intestinal obstruction in infancy. Causing a functional gastric outlet obstruction. Marked hypertrophy and hyperplasia of the two, circular and longitudinal, muscular layers of the pylorus occur, leading to the narrowing of the gastric antrum. The pyloric canal becomes lengthened, and the whole pylorus becomes thickened. Hypertrophic pyloric stenosis usually presents between 2 and 6 weeks of chronological age, with progressive non-bilious vomiting. The causes are multifactorial, with environmental factors and hereditary factors contributing. Possible etiologic factors include deficiency of nitric oxide synthase-containing neurons, abnormal myenteric plexus innervation, infantile hypergastrinemia, exposure to macrolide antibiotics, lack of exposure to vasoactive intestinal peptide in breast milk, and hypersensitivity to motilin. Risk factors include male gender, firstborn, and parental history of HPS, especially if the mother is affected. The infant presents with non-bilious vomiting or regurgitation. Vomiting may initially be infrequent, then occur at nearly every feeding. Vomiting intensity also increases until pathognomonic projectile vomiting ensues. Slight hematemesis of either bright red flecks or a coffee ground appearance is sometimes observed secondary to gastritis or a Mallory-Weiss tear at the gastroesophageal junction. When the obstruction becomes more severe or delayed diagnosis, the infant begins to show signs of dehydration and malnutrition, such as poor weight gain, weight loss, marasmus, decreased urinary output, lethargy, and shock. In the early stage of the disease, the infant remains hungry and sucks vigorously after episodes of vomiting. When examining the child, a firm, non-tender, and mobile hard pylorus can be felt in the right upper quadrant at the lateral edge of the rectus abdominis muscle. This is best palpated after the infant has vomited and when calm, or when the gastric contents have been removed via nasogastric tube. Best felt from the left side with the infant settled and supine. Can observe gastric peristalsis just before emesis or following feed. Assess the degree of dehydration. These features can be depressed fontanelles, dry mucous membranes, decreased tearing, poor skin turgor, and lethargy. Weigh and plot on the growth chart with previous weights if available. Investigating the patient. With IV access, collect complete blood count, pH, BUN, creatinine levels. Capillary or venous blood gas with electrolytes and glucose. Hypochloremic, hypokalemic metabolic alkalosis is the classic electrolyte and acid-base imbalance. This occurs with prolonged vomiting and causes progressive loss of fluids rich in hydrochloric acid, which causes the kidneys to retain hydrogen ions in favor of potassium. The dehydration may result in hypernatremia or hyponatremia and may result in prerenal renal failure. Elevated unconjugated bilirubin levels, where the infant can have jaundice. Blood bicarbonate levels can be used to monitor response to fluid therapy, with typical features of projectile vomiting, visible peristalsis, and a palpable pyloric mass. The diagnosis is almost certain. Nevertheless, to assess the pylorus and confirm the diagnosis, ultrasonography is still advised. Ultrasonography is the imaging modality of choice. It shows a thickened pyloric muscle. Other signs: antral nipple sign, the shoulder sign, and the donut sign. Criteria for making the diagnosis include pyloric muscle wall thickness equal to or greater than 3 mm, and pylorus length greater than 13 mm. The entire pyloric diameter may range from 10 to 14 mm. Upper gastrointestinal barium study, which is rarely performed now, can be done when ultrasonography is non-diagnostic. This shows the shoulder sign and double track sign. Insert a nasogastric tube if profuse vomiting continues despite stopping feeds. Stop oral feeds. Immediate treatment requires correction of fluid loss, electrolytes, and acid-base imbalance. Fluid resuscitation with sodium chloride solution, deficit, and maintenance with sodium chloride and glucose solution. Include potassium in 4 fluids once urine output is adequate. fluid status is corrected in 24 to 48 hours. The definitive treatment for infantile hypertrophic pyloric stenosis is corrective surgery. Surgical correction is usually delayed until correction of dehydration, acid/base status, and electrolyte disturbances. Ramstep pyloromyotomy is the current procedure of choice, during which the underlying anthropyloric mass is split, leaving the mucosal layer intact. Important to fully correct serum bicarbonate before surgery because of the risk of hypoventilation/apnea postoperatively in the setting of a metabolic alkalosis. Thank you so much for joining me today. If you found this video informative or helpful, don't forget to give it a thumbs up and share it with others who may benefit. Subscribe to our channel for more engaging content on various medical topics, and don't hesitate to leave your questions or comments below. Stay curious, stay informed, and stay healthy. See you in the next video.